Welcome to another edition of Throwing Out Some Heavy Light. My name is Aljamal Binder. I'm the chair of the board of Movement Omaha with Race Equity. And we have a special guest today with us, Kendra Ratnadpradipa. I'm probably mispronounced her name. She'll correct me on that. She's assistant professor in the Department of Epidemiology at the University of Nebraska Medical Center in the College of Public Health. She's also associate member of the Fred and Pamela Buffett Cancer Center Cancer Prevention and Control Program. She's been a member of the Nebraska Cancer Registry Advisory Committee since 2020. Dr. Ratnadpradipa has a PhD in public health epidemiology from St. Louis University, a master's from Brigham Young University. She completed a postdoctoral fellowship in transportation injury epidemiology at the Abigail Weiner, I'm not sure, Research Institute, Center for Injury Research and Policy at Nationwide Children's Hospital in Columbia, Ohio. Boy, that's a mouthful. Her research focuses on cancer, health disparities from screening through survivorship. Aspects of her studies include neighborhood deprivation, social determinants of health, healthcare accessibility, utilization, geographic situations, medical accessibility. And she studied driving distance and so on for some people who are involved in some of her studies and so on. I got to know her when we did an interview on one of the programs she's working on or projects related to the Cancer Center. So we had a wonderful discussion. I asked her if she'd one day come on and talk about some of her research, and she also shared some of that with me. I was able to deconstruct it a bit, the best of my limited cognitive ability, but we'll talk more about that as we move forward. And we'll also discuss some of the challenges she faced in dealing with research as related to people of color, particularly in Nebraska, because we don't hear a lot of conversation in the public domain about that. Although she has other studies on rural cancer, that's another topic for another day. And I found that equally fascinating. But again, I think that deserves a topic or interview or conversation by itself. First, Kendra, can you share a little bit more about yourself and maybe get us going forward from here?
Sure. First off, I know my last name can be a bit of a mouthful, so I let students call me Dr. R or Dr. Kendra or just Kendra. So I'm pretty flexible about what I answer
The R,
to.
I like that.
Um, but thank you for having me here. First off, I want y'all that are listening to know that while I'm going to be talking about some of the research that I've conducted, I am speaking as an individual and not as an official representative of the university. And I apologize that my camera keeps having some focus issues. Um, I moved to the Omaha area in 2019, so I've been here just roughly about 6 years. A little bit of background about me to help you understand how that shapes my interests in terms of my research and my professional pathway. I grew up in Southeast Iowa in an economically struggling rural agricultural community. I'm from a huge family, and although my parents valued education, we didn't have a lot of economic resources, and transportation was always a huge issue for me and my siblings getting to and from school activities. And so that's part of my interest in research in terms of transportation and distance to care. Even though I'm in public health now, I don't think I'd ever heard of public health until I was an adult, other than going to get vaccinated to start school. So I didn't really have a great understanding of health or even public health growing up. But my husband was in public health, and so as I got to know him, that kind of sparked my interest in my career trajectory into epidemiology and public health. When I was a young adult, I had already moved away from home when my mom was diagnosed with leukemia. And so I moved back home to help take care of my younger siblings during my mom's first year of recovery after a bone marrow transplant. After her situation stabilized a little bit, I went on and finished my education, and I've moved around quite a bit as an adult. I've lived in a lot of different states, kind of Midwest and East Coast. And so I've also lived in a lot of different settings in terms of large urban areas and suburban areas and rural county seat kind of towns. So all of those factors kind of influence my interest in transportation, interest in rural health, interest in cancer treatment and survivorship, as well as more broadly access to care issues.
Okay. But we're going to run through these questions. I'm going to see if we can kind of maybe brief and do a Cliff Note version for a lot of our listening myself, because we want to get through them. I want to start off by laying the groundwork to some of my questions. The goal is to hopefully engage people in our community and particularly people of color, to participate in clinical research. And again, we're talking about, for me, the focus of Latinos and African Americans, in this case, Native Americans and Asians, because again, those numbers are not always there. But my question is, in clinical trials and address, there's a high disparities in many of those compared to whites. And we see that from the data as I've reviewed in some of the articles, including yours. Why is that so challenging based on your studies dealing with cancer survivors and caregivers' experience in Nebraska?
Sure. There's a lot of different factors at play in terms of the need to diversify clinical trial participation. And your guest last week, Dr. Laura Tenner, did a great job of kind of talking about the importance of clinical trials. Clinical trials really are intended to have cutting edge, the latest advancements in terms of medical care. And so it's really important that we have a diverse group of people participating in the trials to make sure that they're going to work for everybody who may be using those interventions in the future. Particularly for Nebraska and for people of color, there are a lot of factors at play. Historically, there have been a lot of structural missteps by the white research and medical communities in terms of how they've engaged with participants in the past, including the fairly well-known Tuskegee syphilis study,
Right.
which really has very long-standing intergenerational consequences
Right.
in terms of trust in the medical and research communities that we're still trying to overcome the consequences of that. But some other factors at play are whether or not there's clinical trials being offered nearby. So while Buffett Cancer Center does have clinical trials, people may not qualify for all of the clinical trials just because of different other diseases that they might have at the same time. And so sometimes eligibility becomes an issue. And sometimes the providers just aren't asking people. So there has been research that's been done that when people are actually asked, participation rates are similar. And so part of it is educating our medical community to make sure that they're extending that invitation to participate to all patients.
Let me interrupt you. And I
Yep.
want to move up a little quick if I can. Some of us don't know what a clinical trial is. What is a clinical trial?
Yep, sure. Let me get
Give me a
back to
layman's
that.
version, like a real quick. What is a clinical trial?
So, clinical trials are intended to be well-designed research studies
Okay.
that are testing new medical treatments. Those could be drugs, devices, surgical procedures, or even behavioral intervention or prevention programs. Typically, they are comparing what the standard of care is to something that's new, that's already been kind of pre-tested in smaller groups to make sure that it's relatively safe.
Okay.
But the clinical trials are opportunities to get cutting edge, specifically in cancer care, potentially medications or different combinations of medications that may not be on the general market yet.
Gotcha. Okay. So I'm gonna kind of switch up real quick as I want to get through as many as I can so we can open it up because I'm sure some of my participants have questions. I took several notes in areas of your findings and observations in some of your research, and you indicated a small number of participants in some areas. You also indicated one study you had a hard time finding Latino males. I'm like, okay, what does that do to the study? So my question is, you revealed that some of those studies took place during COVID. And I'm okay, well, how does that work if you can't get the people to participate? So would it have been better for you just to wait until after COVID was after to do your clinical trials or your research?
Yeah, so sometimes, like with COVID, we didn't know exactly when it was going to end. So, like looking back in hindsight, it might be easy to say that, but at the time, let me just kind of contextualize a little bit more for you in terms of the focus group studies that you're referencing. So those were conducted in 2020, 2021. The Buffett Cancer Center was trying to get their newly created Office of Community Outreach and Engagement off the ground at the time, which is one of their requirements for National Cancer Institute Cancer Center designation. It had been a long-standing need, and they were finally putting the resources toward getting that COE office up and running. And so I am not a member of the COE office, but I was working with Dr. Shinobu Watanabe Galloway, who was tasked to kind of get that office started. And so we started out with just doing a statewide needs assessment to try to inform what the priorities for that COE office were. So it was kind of time sensitive in terms of trying to get that needs assessment up and running and off the ground. So those focus groups, we put a lot of time and effort into planning them and trying to extend the recruitment time, but at a certain point, we had to say we need to just move forward with the number of participants that we were able to get. That's not to say that there won't be follow-up studies or opportunities for involvement of community members further down the line, but in terms of this particular needs assessment, it was somewhat time sensitive.
In other words, you're under pressure. Now, again, I'm switch up. I'm going external to your system somewhat, but some years ago, the Children's Hospital hired a person who I knew, a really nice guy from the community who had a lot of skill set, credible messenger, and they made him a patient navigator. Never heard of that term back in the day, okay? And he was some person of color who had deep roots in the community. He also had some good roots with low-income people in general, just the way he engaged. Would that help from your perspective dealing with in your studies in institutions such as healthcare in your institution to bring more people into your system? These clinical trials are just building a better social capital. An average.
Yeah, social capital is super important in terms of trying to help get participation in all different kinds of studies, as well as connecting people with resources and support services. So absolutely, yes. Patient navigators, community health workers are also an important part of helping connect people. Patient navigators are something that was tried in clinical trials to see if it's a worthwhile investment in healthcare systems to try to help support their patients. And so that has been found to be very beneficial.
Okay.
So it kind of depends on the healthcare system and how siloed their cancer or other services are, whether there's a patient navigator assigned. Some patient navigators are trained nurses. Others are people who may have had that diagnosis in the past and are considered lay individuals who then go through additional training to serve as navigators to help patients and their families.
Yeah, and I like that because I think it's one thing to talk to someone who's been through the experience or who has what we call lived experience, or we could use the word credible messenger in the community. You really resonate with them a little bit more because they know what you're talking about. And sometimes you don't have to start on point A. You go all the way down to midpoint of the conversation and deal with that. Now, in your community needs assessment as I read that article, I thought it was excellent. I really loved the way it was laid out. It was engaging. What were the major issues that bear implications on our audience? And also, as a follow-up, can some of the medical practitioners, scientists make internal changes to deconstruct their work? And basically, I'm saying, even in spite of what you did and it's clear and I understood it, can we do even more to deconstruct some of this academic, scientific work to help lay people like me understand?
Sure. Yeah. I think it's important that I think one of the things that kind of came out of COVID is that the scientific community is really good at talking to each other and talking to ourselves.
Talking over
And we
my
haven't
head,
necessarily
okay.
done such a great job at reaching out to the broader public and really telling them about our work. And so I think that your interviews here are a great opportunity to try to help start bridging that gap. Some of the identified needs at the community level from those focus groups that we conducted were really central around healthcare access and accessibility. So insurance is a huge thing, whether that's assistance applying for government-supported assistance such as Medicaid or Medicare, or whether that's help navigating the health insurance marketplace. Those are definitely kind of system level things that need to be better addressed. But one of the things that came up repeatedly in our focus groups was that some people didn't really understand the importance of preventative care. So with the Affordable Care Act, health insurance is supposed to cover preventative care, once a year annual wellness visits. But people don't necessarily know that that's supposed to be covered. That it's not supposed to have any copays. It's supposed to facilitate people establishing a relationship with their healthcare providers. So people who are underinsured or uninsured may not be taking advantage of those opportunities. And some communities have a culture of not actually seeking medical care unless they're experiencing really severe symptoms. And some of that's economically driven. If you're a low paid hourly worker, every hour that you're not at work is loss of income for your family. And so that was repeatedly brought up as well. So are there things that we as a society can do to try to intervene on those? You bet. Maybe we extend healthcare into the workplace so people aren't having to leave work to actually go and get checked up. Extending office hours into evenings and weekends, like on the healthcare provider side of things, the health system provider side of things. Having our health care providers reflect the communities that they're serving was another issue that came up quite often. That the people that were treating the patients didn't look like the patients and
Right.
didn't communicate well with the patients. Health education for our providers in terms of really listening to understand what the patients are telling them. There were several stories that were shared with us about going in and expressing concern about symptoms and the provider not taking those concerns seriously. So those are all things that
Right.
can potentially be addressed.
Right. Now, the statement you indicated that particular group was very effective in one of your studies, and many of us questioned the data. In other words, oftentimes we're practitioners, scientists say, "Oh, we're really good," but then when I look at the data on the larger scale, it doesn't always look that. We can offer praise to the numbers on one level, but then we look at the raw numbers in Nebraska. How effective are we? And so, basically, I'm asking, is the jury still out if we're that good? And then I saw a billboard, by the way, for the first time, I want to say second, third time from the system where they had an African American on Northwest Radio Highway. And then I remember years ago, there was a person I knew who was included in some kind of medical support thing, or he was a success model. And like I say, I've been in the city almost all of my life, and it's rare that I've seen people of color. So my question is, help me understand how can we get the systems and providers and people to bring more grassroots and people of color into the what you do so that we can help deal with cancer in Nebraska? Long-winded question. What can we
Yeah, no,
you kind of alluded to it a little bit earlier, but what can we do? Because I thought the billboards were effective. Like I say, I shouldn't be able to say as a community member, I've only seen diversity twice or three times in our community from institutions that are doing good work.
yeah. So one of the points of feedback that we got from those focus groups was that the healthcare systems, representatives of the healthcare systems, really need to be out in the community
Okay.
more. So if there are walks for different health topics that, like me as an employee of the University of Nebraska Medical Center, like if I'm there to let people know that I'm there,
Hmm.
to let them know that they're being seen, that they're being heard. So for example, and this is just kind of low-hanging fruit example, but in my college, we have flyers up in our workroom notifying the community, the workers, that there is a sickle cell walk on
Oh,
the
okay.
like at the end of this month at one of the parks in kind of North Omaha.
Wow.
So just being there, being present, knowing about what's happening in the community and showing up, having tables at community health fairs and branding that we're here representing Nebraska medicine or that we're here branding the different organizations that we participate in so that we can start establishing those relationships
Wow.
and start establishing that trust.
I like that.
To your point about the billboards, yeah, I saw one about a African American female cancer survivor that was up kind of near Dodge Street.
Oh, you went
And
over there too. Okay. I just saw one on one.
yeah,
That's right. I didn't
that
drive
was
over to
like a
look at
year or
that
so
one.
ago.
Okay. Wow.
But those are all kind of outreach efforts that need to be happening more often.
Good, good. Now, in your paper on colon cancer, you screening for African Americans, Latino population in Nebraska, some aspects were not clear to me. You mentioned some term called precept, predisposition, reinforcing, enabling, constructing, education, diagnosis, and evaluation. Deconstruct what that means. I have no clue what you're talking about, even though I read the thing two or three different times, yada, yada, yada. What is that
Yeah,
all about?
sure. So it's the pre-seed framework for assessing health needs and program evaluation. So it's a kind of a theoretical model or a way to frame program evaluation. So pre-seed stands for predisposing, which is a shortened way of saying that we're looking at individual people's knowledge, attitudes, beliefs, their personal preferences, their
Okay,
existing skill sets.
okay,
So what types of things predispose them to certain behaviors? Reinforcing refers to factors that either reward or reinforce desired behavior change. So, for example, if we want people to go get colorectal cancer screening, some have offered cash incentives so that when people return the test result, they get like a small gift card.
okay.
So, those types of things are reinforcing or rewarding that behavior. So those can be social support rewards, those can be economic rewards, it can be changing the general social norms, anything that's reinforcing the behavior that we're trying to get people to adapt. Enabling constructs refer to skills or physical factors such as accessibility and availability of resources or services that actually facilitate the behavior change. So if we're asking people to go get screened for colorectal cancer, we need to make sure that they have the test kits available. We need to make sure that it's easy for them to access that and to return it. So that's kind of the long-winded way of explaining what the pre-seed model is. It's really a framework that people who are trying to instigate interventions, especially behavioral health interventions, use to just frame what they're looking at and how they're looking at the problem.
Good. Now, I noticed that in one of your papers, you use a lot of methodology in the middle of the paper, which I thought it should have been at the end of the paper in the footnote. And so on, those of us who do a little quasi research and understand methodology and qualitative data. In the body of the paper, would it have been better to put that analysis and all that stuff at the end? Because I looked at them like, okay, why are you telling me all the details in the middle of a paper when I'm expecting to see all your footnotes and all those kind of methodology at the back? It helped me with that was different for me to read that. Or
Yeah, so again, as I mentioned, researchers are really good at talking to other researchers, and that's just a general format for peer-reviewed research publications, is that they want a lot of detail about the methods so that other people can assess whether it was done appropriately or if there are some sort of inherent bias in how the study was conducted. So among researchers, the methods really are one of the core pieces of, like, we can't trust the results if we don't think the study was conducted well enough.
gotcha.
And so we want to really assess the quality of the study by looking at those methods. When we're talking to non-research community members, we need to really focus more on the results and the implications of the
Okay.
results.
Gotcha.
But when we're talking to ourselves, particularly when we're publishing in scientific or research-based journals, the methods really are kind of the key to whether we think it was a quality study.
Gotcha. Gotcha. Another thing I was thinking, you may have to have a Cliff Note version of each one of your things as they do in some report. They have the executive summary for the lay people, then they have the academic one for those who of us maybe in terms of that. Now, I know we only got a couple of more minutes before we open up, but it was exciting that you suggested very much increasing screening. And my point is, how can that be increased or implemented in terms of our Nebraska? And also, does federal funding and insurance help us to play that role? Again, we have to deal with the companies out there and corporations, but you made some good suggestions about it. I wonder how is that possible? Is that looking at all the factors we have to deal with in Nebraska?
Yeah, so again, preventative screening, like cancer screenings, are supposed to be covered by insurance to make it easier for people to actually do those preventative services that in the long run actually save money. If we're able to catch cancer early, it's easier to treat, it's less expensive to treat, and the people who are having that cancer usually have better outcomes. So it's more cost effective for practically everybody who's involved if we can catch the cancer earlier. And one way of catching it earlier is to do screening before people have severe symptoms. So I'm not personally involved in the project that I'm going to tell you about now, but we have people at the College of Public Health who are trying to improve colorectal cancer screening in North and South Omaha. And so one of the methods that they've taken is to actually have a little kiosk or a table at the DMV so that when people are going in to do business related to getting their driver's license, they see the table there. They can get a free test kit. It doesn't cost them anything to do the cancer screening with the fecal test kit. And then the big step after that is if people have positive results, linking them to services for follow-up diagnostic colonoscopy. And so they've been working with different medical providers to try to make sure that anybody who has a positive test can actually get that diagnostic follow-up that they need.
By the way, I actually went to the DMV and saw an African American woman in North Omaha about what 50th and Ames Street, and she was sitting at the table and asked me the question like, "Wow, it's the first time I've seen something like this." And she was asking everyone who walked in the door, so I was like, "Wow, this is impressive." So yeah, I actually saw
Yeah, that's a relatively that was a pilot study by one of my colleagues at the College of Public Health, J.Y. Kim. And they're currently seeking funding to try to extend that.
wow, because we all have to go and get our license renewal, especially those every 4 years, and some of us have to pass the driving test and whatever. We're down to the last few minutes before we open up, but one of the factors in Nebraska is the unicameral was to focus on change in many areas for Nebraska. We tend to be unicameral or legislative centric in the state, obviously. Could some of these areas be done in collaboration with other healthcare providers instead of making a public policy or passing laws? In other words, sometimes we want to run down to Lincoln and make a law. Sometimes we want to do this. But could some of the things that you talk about be done by just us working across systems and institutions, whether it be CHI, you name it, methods, whoever, to deal with some of the things we were talking about in your studies?
Yeah, definitely some of those things are things that are system level changes that can be made, such as making sure that the providers are really listening to their patients, right? That's a medical education um, intervention that happens at the medical schools. Or that happens through review of the medical provider's evaluation of how they're interacting with their own patients. Some of those things may be just pushing for the healthcare systems to extend their hours into evenings or weekends,
Mhm.
just to make sure that people who are working full time have other opportunities to get in and be seen. Um, I don't think that everything necessarily has to happen through public policy, although public policy does play a very large role. So, kind of at the federal level, the Affordable Care Act and making sure that preventative care was covered so people aren't having to pay out of pocket for it. Um, Not that everything about the Affordable Care Act is working the way it was intended, but that is something that is like a policy that has had very long-lasting direct implications.
Yeah. We're down to the last minute, but I want to throw this out to you. I noticed in one of your studies, you said there were only females in a Hispanic study. I noticed the limitation study was that a cop out? In other words, if you're going to interview and deal with Hispanics in general, shouldn't you have male and females? And should you continue that study or not make it happen? I noticed that one of your studies you said cited that.
Yeah, we worked with lots of different community partners to try to recruit Hispanic males to participate. Um, and yeah, it was very unfortunate that we weren't more successful in we weren't successful at all in getting them to participate. So part of that is again the social connections, the community connections, leveraging social networks and that sort of thing. Um, I hope that in the future that they have an opportunity to kind of repeat that study and to include them. But we felt that it was worthwhile enough to at least include the voices that we did have, to go ahead and share out what we did have. But um, historically, it has been really difficult for researchers to get participation from different community members. We had also tried to recruit participants from our LGBTQIA community to participate in focus groups, and had very low participation rates. So that's one that I'm no longer a part of that needs assessment team. I'm not quite sure what studies they have planned or what are ongoing, but that was one where we were actively trying to recruit additional individuals, even if it meant doing individual interviews rather than focus groups.
Good. We're down to the last one. So any comments, things you want to say before we open up to our participants who've been listening and participating so far? Anything you want to say, Dr. Kendra?
Sure. I would encourage everybody to try to make use of preventative cancer screenings and preventative care visits whenever possible. That was one of the things that really struck with me in doing these interviews is that if people are waiting to go see the doctor until they feel like they're dying or they have such severe symptoms that they can't function, we've really missed an opportunity to intervene earlier where it would have been easier and safer and more effective. So just helping people understand the role of going to a medical provider. It's not just to, I think that contributes to part of the idea that a cancer is a death sentence, which is what we heard quite a bit as well. Is if people are waiting until it's spread throughout the body, it is much harder to treat. And so intervening earlier is much better.
Good. Appreciate it. Folks, we're going to open it up right now. Anyone that asks Dr. Kendra any questions, anything, comments, something she said, this is your time. Also in the chat, if somebody want to put something in the chat also. And while people are thinking or noting or getting their questions or comments together, are you full-time in the system or do you work in other systems or are you exclusively, Kendra, in that system there?
Yeah, so I work full time at the College of Public Health. I split my time between research and teaching and some administrative responsibilities.
Okay. Yeah, matter of fact, years ago, I know Creighton universities bring community people to their medical studies. Students, they would come in and talk about some of their lived experience. I don't know if they do that again or they're continuing that, but people come in and share some of their stories, and sometimes were positive, some was negative, but they always had that, particularly in, for the health education for potential healthcare providers. And I think it was doctors, healthcare nurses, you name it, along the whole continuum. So it's one of the things. Any comments, other feedback, folks out there?
Uh, Looks like Cynthia has her hand
Cynthia,
raised.
go ahead, Cynthia.
Oops. God, I had my camera off. Okay. Um, Thank you very much, Kendra, for the research. If I was younger, I would be tuning in a lot stronger. I was a science teacher for most of my teaching career, and the students really liked the hands-on things. And I'm wondering, what is your connection or what's the outreach that you have seen or do to like college students, not college, high school students? I taught mostly like sixth, seventh, and eighth grade, and they're the ones that I think is where to plant seeds for things like, if you can take this piece of wire and do this experiment and you get the procedure, etc. You know how it is. But
Yeah.
teaching them the method and having them do simple little experiments in class, I think it nurtures the desire to, I want to do some research. So that's what I wanted to comment on.
Yeah. There are different programs that try to reach out to the high schools. So over time, I don't know that our local community necessarily has it. I'm personally not connected with the local school systems as much as I have been in other states where I've lived. But there are programs such as science competitions that look at infectious disease investigations and kind of be problem solvers. So there are resources like that that are available. There are curricular materials that are designed to help teach about epidemiology, for example. Just to introduce people, like I said, I didn't really know anything about public health growing up, and having opportunities to participate in kind of disease investigation competitions would have been right up my alley in terms of what my interests were, but it just wasn't available where I grew up. So anything that we can do to try to get public health into the school systems, I think is a win-win.
Wow. I like that because at the end of the day, kids at a younger age see things, and it'd be nice to get that interest where it becomes a track record where they go. And I know when I was an undergraduate, back in the day when I was in high school, I thought about my major before I even went to the university. So again, the more we introduce practitioners and people, fresh and different level, can help our system. There's a question in the chat that says, how do cancer prevention survivorship challenge differ from rural versus urban residents in Nebraska? And that was not my question. So again,
Yep.
I'm throwing it out at you. I was trying to play safety with you on that one, but yeah, somebody threw it out at you.
No, that's fine. I know, Jamal, that you had talked about maybe having a follow-up discussion specifically about rural care, but there are fewer resources for rural residents. So, like survivorship clinics, support groups for cancer survivors or family members may have to be via telehealth or virtual platforms like Zoom rather than being in person just because of travel time and travel distance. Some of the resources that are available are more available in urban areas than they are in rural areas. So the Buffett Cancer Center Office of Community Outreach and Engagement is really trying to do a lot of outreach with our rural communities to try to promote the idea that you need to be aware of cancer, that you should be getting screened for cancer if you're age eligible. But there's still a lot of work that needs to be done in that area.
By the way,
Some of the support services that are available through the cancer center, such as like transportation assistance, if you're in an urban area, they may be able to help with rides more directly than if you live in a rural area where they might just be able to give you a gas card, for example.
I was going to say I had a chance to go to the University of Kearney for the first time about a month or so ago, and I'm surprised the Buffett Institute is out there. So again, one of the things that I learned is that by being in rural communities and building that social capital with farmers in rural communities, they suffer and experience some of the same things as you alluded to, Dr. Kendra, the transportation, gasoline, vast distances, and even the social support system we may have in a city versus rural areas, or you have farms that are like miles away from each other can be another thing. So again, we have Western Nebraska that we need to also pay attention to because again, we look at our numbers, they're not just Omaha or Lincoln or North Platte or again, Verdigris or Table Rock. It's about the whole state. So again, we have to look at that. But I do like the fact that there was a location far away from the eastern part of of Nebraska. I almost said the United States, but Nebraska. Well, yeah.
Yeah, Nebraska Medicine has actively been trying to expand their footprint in some of our more rural communities. I saw like an announcement that they were doing groundbreaking for something in Grand Island. I'm not sure what that was about because I'm not directly involved with that, but they are expanding in Kearney and in Grand Island for sure.
Somebody says here, or a question here says, do they do cancer screening on physical exams or annual checkups in the medical system as a whole? Are you aware of that, or do they do anything like that?
Yeah, so the different types of cancer have different screenings that are recommended for them. So, for example, as a female, if I go in for my annual checkup, they're not going to do the mammography right then and there. I need to schedule a follow-up appointment with the mammography center to go get my breast cancer screening. Typically, if you're age eligible, hopefully your provider is telling you what screenings you should be getting and they're recommending them to you and potentially even helping facilitate scheduling of those appointments, but they generally are separate appointments. For colorectal cancer screening, there's multiple different ways of doing that screening. So some providers are actually passing out what are called FIT tests, where you take a sample of your stool and you put it on a little card and you mail it into the lab. So for the stool-based ones, they can actually give you the kit, similar to what I was talking about at the DMV, where they can actually give you the kit and then you do it in the privacy of your own home and mail it back. But if you need to do a colonoscopy, which is a more invasive exam, then that's definitely a separate appointment that needs to be scheduled. Breast cancer, if they're just doing the like I said, the mammography, they can do kind of the palpitation to see if they feel any lumps, but the mammography is really the recommended screening for that. Prostate cancer, again, that's kind of provider-based. Not being male, I'm not exactly sure if they can do that during the annual physical right then and there. The screening for the prostate-specific antigen is a blood draw, so they could do the lab right then and there.
Wow. By the way, speaking of the types of cancer, years ago I learned that Richard Roundtree, the actor, had breast cancer. And again, you don't normally think of men with breast cancer, but that was that. And then the other thing related to that is that oftentimes people are concerned about the cost. So, like say, example, if you want a colon screening cancer where you actually do the actual invasion or use the surgery thing or whatever, that costs a certain amount of money. So if the insurance company won't pay for it, I heard it costs like thousands of dollars. So can you expect a person who's nervous about colon cancer to come out of pocket and pay like 5, 10, whatever, $20,000 for that exam? Because I know it's age-based. And again, when you get to people of color, African Americans particularly, they have a higher mobility rate or death rate from colon cancer. So my question basically is, how do you approach all those complex issues, money and also gender issues?
Yeah, so the the preventative screening is supposed to be covered
By
um,
insurance.
by the insurance. If you have to go back and do some sort of follow-up, then that's where cost may become an issue.
Okay.
I don't want to scare people off from doing the follow-up. The follow-up's really important. So for example, I am of age to actually have colorectal cancer screening. I had a colonoscopy and they discovered that I had a polyp and they weren't able to remove it during that actual procedure. So I had to go back and do a follow-up procedure for them to remove the polyp. And that did cost me out of pocket for that follow-up procedure. But removing the polyp is a way of preventing cancer because some polyps do go on to become cancer. So that's still where you were talking, Ajamal, about like policy and what can we do, like making sure that those follow-up diagnostic is also covered is an important health insurance policy piece that still needs some work.
Hmm. By the way, I'm working right now with some folks in the public health, not the university in Douglas County, talk about years of life loss in terms of longevity of different racial groups in Nebraska. And some of it has to do with healthcare. In other words,
A lot
accidents
of it
are
has
one
to do.
thing, but if you don't get preventive health care, if you don't have insurance, and how do we increase that? But the other issue I think is probably the most important is community education of why we need to do certain differently to last longer, to live longer, because some of the things that people die from prematurely can be prevented just by basic community education. So hopefully we can look at those data and numbers and show the disparities between whites, Latinos, Asians, Native Americans, so on. It can get people to say, why are all groups have these great disparities? What can we do to normalize it? Normalize it meaning they should have to be across the board almost equal, and money and issues should not be a factor in people getting preventative health care in a country or state that has this much money. So big issue. I was going to ask you a different question. It's kind of a kind of unusual question in terms of this. When you are doing your research and you make recommendations, oftentimes in policy recommendation, do you go back and replicate your studies, or are you expecting other people to come back and replicate your studies from a completely different institution? In other words, is there a warm handoff to some researcher or another entity who works in your system who's kind of like pick the baton up and run with it to try to implement some of the stuff you suggested in your studies?
Yeah, so that's a great question. There can be warm handoffs if you are already connected with people who are doing kind of the next step of the research, or if you're able to kind of build out your research program to receive grant funding to do implementation science, to actually come up with interventions. Um, as an epidemiologist, I'm more on kind of the research, the statistics part of things, and not so much on the developing of interventions. And so that's where it becomes important for me to make connections with researchers who are doing the next step type of projects. Um, so, for example, the project that I actually got connected with Ajamal on is looking at trying to increase participation in clinical trials. That's not really my area of expertise, but I am collaborating with somebody who is a communications specialist. And so those are the types of connections that need to be made to actually do the next step and to implement the next step. Um,
Good. By the way, I saw a couple of articles in the New York Times. I do read the New York Times, and there's a great pushback on funding and supporting cancer research and so on. Again, there's some great articles that just came in the last couple of days, and some of it is crazy about cuts where we can actually save lives. So my question is, will that have an impact on your research studies? Because I assume you get some money from the National Health Institute and those other entities out there.
yes, the changes that the current administration is implementing have put preventative health and healthcare and public health in a little bit of a frenzy in terms of not knowing quite what to expect, or there's a lack of predictability that used to be there in terms of what funding was available or how to word things when applying for funding. So we're all on a little bit of a learning curve in terms of like adjusting to all of those changes. There is still grant funding through the National Institutes of Health that's available. We're hoping that things get a little bit more back on track. But some of us have to be a little bit more circumspect in terms of how we're wording things. To, for example, downplay issues of diversity, or to expand what we're talking about when we talk about diversity, and to not necessarily focus on specific subgroups of people, but to say, like, this is how it helps everybody.
And one of the issues I've seen is dog whistle code words, where people will say stuff like certain parts of geographic areas, rural, urban, da da da, age demographics, gender, you name it. And you can also capture people low income. Again, there's a high percentage of people of color who suffer or have poverty situations where they're low income. So that'd be it. Hey, I know there's two questions on my one is I noticed you had a lot of people in your studies. Why do you got so many people working on the studies? How does that work out when you got five researchers or seven researchers on one study? Wouldn't you just, shouldn't it be better just have one of y'all write the thing and have somebody critique it and you take credit for it?
Yeah, that's a great question. Like I said, I had only been in Nebraska for a fairly short amount of time before I was asked if I would help participate on this study. At least, and it may differ based on researcher and based on kind of research group norms, but at least in the projects that I work on, if people have contributed to the project and they meet the peer-reviewed publications have authorship guidelines because we don't want to just be putting people's names on things because they're a supervisor or a supervisor's supervisor and we want to look good for our boss. We really do have authorship guidelines asking like, what did people actually do that contributed to the project? And as long as people meet those authorship guidelines, I personally am fairly open to including everybody who helped on the project who meets those authorship guidelines. So for the projects that are related to this needs assessment study, we included our community partners on all of our publications. So we worked with the state comprehensive cancer control program, the representative that we worked with that helped kind of plan the project from the very initial stages and met with us throughout the process. She's included on those studies when she was allowed with the state authorship guidelines. We included community partners, people who helped us conduct the research from the Centers for Reducing Health Disparities were included, people who helped us coordinate the study. If they were willing to review our manuscripts and make critical revisions to them were included in the studies.
Wow. Well, you know what? Maybe you should go back to the ARB different people and say, let's include that guy who does the more interview after he critique your whatever after the fact. After this, oh, just kidding, joking.
No, like if I were to work with you on a project, yes, I would extend co-authorship to you and then let you choose whether you wanted to participate.
And the names are all at the top of the heading of that study, is what I noticed. Our acknowledgement at the end.
Typically in peer-reviewed, like professional publication journals, you'll have the title of the article and then a byline with all of the authors listed.
Okay, good. And then something else that hit me in terms of community education. When you do your research studies, I know you talked about being a professor and talking in your academic classes. Do you ever share some of your studies in some of your contexts of your courses that you're dealing with ethnology and so on?
When I'm teaching classes, yes, sometimes I will share like personal research experiences. So for example, I'm currently teaching chronic disease prevention and control. And so when we talk about designing surveys, I will share with them some of the experiences that I've had in terms of survey design or talking about trying to recruit people, like different methods of recruitment. So yes, I do try to not overwhelm the students with my own work because I don't claim to be the omniscient person that knows everything. But I do try to share personal experiences with research when I'm talking with my students.
By the way, Dr. Kendra, one of the things that I've been challenged with over the years when I used to teach is using a textbook or edited version, whatever, versus using articles across the internet or whatever. So my point is, how do you do your classes? Are they kind of like a textbook when you teach courses, or do you just grab stuff from eclectic sources throughout the academic subject area that you're working on?
At least for myself as an instructor, I typically will have a textbook that's assigned, and then it's supplemented with more recent or even like more historical kind of key articles. And so it's a mix of both a textbook as well as like published journal articles.
By the way, I was in a community event, and one of the things I didn't know this, but some of the community events they offer, you alluded to gift cards of $50. Like, what are you doing? $50. Some people want to do it for free. Some people just want to help the community, and sometimes that could drive the costs up. And I have no clue what you pay for a clinical research trial. So when you get support from the National Health Institution or whatever, what kind of money are we talking? Again, I don't know if it's $100, 200, thousands, whatever. What is the average cost, would you say, if you had to look back at some of your research that is supported by the federal government? And also it's contrasted what is supported by the local institutions, whether it be the health entity in and of itself or the foundation. So give me a little numbers if you can.
Sure. And again, for anyone who joined last week's interview with Dr. Tenner, she talked a little bit about paying participants for their time in participating in research studies. Ethically, researchers have kind of a fine line that they have to walk. We don't want to offer so much money that it becomes coercive, where we may be recruiting people who wouldn't choose to participate, except that it's such a large amount of money that they feel like they have to because they need the money. But at the same time, we want to acknowledge that we're using your time and want to thank you for your participation. So depending on the study and how involved the study is, how much time is involved in the study, participant compensation, at least in studies that I've been involved with, has ranged from $25 to about $50. Um, and that's typical for if you were participating in a one-time interview or a one-time focus group that might last an hour to an hour and a half. That's typically what we're providing for compensation. When I've done survey-based research that's more kind of anonymous surveys, there hasn't really been any compensation for participation. Sometimes if it's a mailed survey, we had like a $1 thank you for at least opening our letter and looking at the survey, but there was no additional compensation. So it really depends on the type of the study, the amount of time and effort that's involved by the participants in terms of what they're compensated.
Well,
And our,
go ahead.
yep.
I was going to
I was
ask,
just going to say,
go ahead.
our institutional review board has to review our study proposals before we start conducting the research. And if we've set the compensation higher than what they think is ethical, they will let us know and we'll adjust it accordingly.
So there's an internal safeguard, or let's say auditor internally look at that. My real question was, how much is a study worth in general when you get from the federal government? I assume they varies, but is there a range like 50,000, 30,000? And again, your time away from your class, whatever. What kind of numbers? I have no clue what folks get for doing research.
Sure. It depends on the type of funding mechanism and what is actually being proposed for the research. So for just like a really broad-based statement in terms of funding. So some of the funding mechanisms, research funding mechanisms that I, as a faculty member, am potentially applying for, the NIH or the National Institutes of Health have different number system based on what type of grant it is. So an R03 grant is a 2-year grant that's capped at $50,000 per year.
Gotcha.
An R01 grant is up to 5 years, and it's typically about $1 million a year that you can request funding for. You can go over that, but you have to have a really good justification for why the project that you're proposing exceeds that amount. They have an R21 funding mechanism that's, again, about a 2-year project time frame, and it's significantly less than the R01. So it depends on the type of project, what funding mechanism you're applying for, and they're not just going to give you the flat amount. You have to submit a budget and justify why you are asking for the amount of money that you're asking for.
And do they give you money straight up front? You get the money as soon as you submit it, they give you a lump sum of whatever that is?
Nope. There's a lot of contracting.
Wait, hold on. Why are you laughing? I mean, if they agree to give you 50,000, why are they holding it back? They might change your mind.
Well, that was one of the issues that we saw with some of the pullback on federal funding earlier this year, was that some grants that had been approved and had already had funds released, the federal government decided to pull back some of that funding.
Wait, hold on. They put the money in your head and then they took it back out?
Not me personally. I didn't have any grants that were currently funded and affected.
That's terrible.
But there are a lot of hoops to go through in terms of the university and the university contracting office and the university financial auditing people. It goes through a lot of hands before it actually gets paid out.
You know, the reason I'm somewhat comical, but I find this funny is that I've listened and I've learned over the years. I'm not going to mention the department in general, but there are money that they don't spend, which we should have spent because they couldn't figure out what to do with the money or was already allocated. They have to return it. I'm like, hold it. There are many of us in the community who can figure out all kinds of ways to spend money in Nebraska to help people here in the state. So I find it almost sad or painful when I see that our institutions have not figured out how to draw down on certain money. And particularly, I remember during COVID, there was a certain amount of money that had deadlines and they didn't expend it because they didn't have the community people at the table help decide what some of the greatest needs are, or they may go out and do some frivolous things that does not qualify for that grant. So I think it's very important to have Nebraskans at that table to say, hey, we know where best to spend public money, particularly if it's federal money that we paid out to the federal government. We want to return it back to Nebraska. That's a big issue. We're down to about the last 5 minutes on the show. And I wanted to, before we close out, to say to you, What are some of the future things you look in terms of if you had a magic wand research you want to do to help improve the kind of area that you're working in, Dr. Kendra?
Sure. For me personally, I would like to make deeper connections with people who are actually doing interventions, um, to move my research from just here's what we're finding to actually, so what, like what are we doing about it? So for me personally, like connecting with people who are more in that health promotion, development of programming and interventions, is definitely something that I want for myself. I see a comment in chat that just popped up from Cecilia. Is a holistic approach to cancer treatment considered taboo? Even if combined with prescription medications or methods, my doctors do not connect a symptom relationship with my lifestyle so much that my therapist, who really listens to what goes on with me, has been able to diagnose and discover the cause that was overlooked. I think that varies from provider to provider. Some cancer centers actually have, as part of their cancer center, alternative medicine where you can go in and do acupuncture and you can do mindfulness training. So depending on your provider and depending on your where you're receiving care, there may be more or less supports that are available. I would say for me personally, I think having that holistic approach to cancer is really important. I think that there's a lot that goes on psychologically with not just the person who's diagnosed with cancer, but their support system, that is often overlooked. I think that's a really important piece to it. I would say also, with my social work background, that, and this kind of ties into what your previous question was, Ajamal, was like, what would I like to see? I really do think that there needs to be a lot more support around those social supports that are needed. So when someone's diagnosed with cancer, they often are just overwhelmed with the
Right.
diagnosis. Like, what
Uh,
does this mean? What does this mean for myself, for my family? And so even if social supports are offered at the time of diagnosis, we need to keep asking repeatedly, what supports do you need now as they continue through that journey? Because it's not a one-time need. And people's needs change over time, and we need to be adaptable to that.
No, appreciate it. We're getting out to the very end almost, but I wanted to say thank you very much, Dr. Kendra, for sharing some insights. We don't get a chance to do this, particularly in the medical field, because we don't oftentimes have an opportunity to deconstruct research and bring people who are practitioners and scientists into our community to talk about these issues, but really appreciate that. But one thing I do want to share, and it related to something you just said, and I think it's probably very important. Dr. Tanner alluded to it last week. Sometimes people in the community may come with some sound like outlandish, laughable things and just, where they're coming from. And we have to respect that. And then, we may have a little snicker under our throat or whatever. But when you're in communities with people, you probably need to bring people together in a community to help people deal with that. Because again, as you alluded to cancer, people are desperate and they may go to various places. I'm not going to mention nobody's name, but there's a female colleague who had suffered from cancer years ago, and she ran down to Kansas City to all the advertisement. She came back. She says, "Hey, they were no better than what we have in Nebraska." And in fact, her testimony was it was better in Nebraska. Plus, she'd have to drive all the way down to Kansas City for it. So one of the things I think we need to do is a better job of being a sense of humility and being careful not to laugh, because some of the stuff is funny when somebody say, "But walk on wet grass in Mexico, you can cure my cancer." But you got to keep a straight face and again help walk people to say maybe the evidence doesn't prove that. And then some of us need to be sensitive to maybe that might be a future research study, because again, some of the great discoveries of the world were done by people who were on the fringe. And so I really appreciate you sharing what you've done. And hopefully, as we go forward in the future, we can deconstruct more conversations on healthcare issues, not just cancer, but other healthcare issues where we have these disparities. So thank you very much for being on this program, throwing out some heavy light.
Well, thank you. I appreciate the opportunity to extend my social network in talking with you all. I would encourage people to look at the Buffett Cancer Center's Office of Community Outreach and Engagement website. They are trying to really reach out to the community, be more involved in the community. And as you were talking about, like some of the publications might be a little bit difficult to decipher. They have been trying to put like infographics that are available that are like more snapshots in terms of what does the public need to know about this. So they do have some other resources there as well.
And the other thing I would allude to, I did find that there's some other publications internally to the system that I had no clue it even existed. A little glossy and nice, but again, if you don't have the population who can read it or have it, access to it, or even know about it, what good is it? Again, sitting in the corner on the desk. So thank you very much. And we hope you've enjoyed this edition of Throwing Out Some Heavy Light. Join us again next week for another edition. As we always end, may the force be with you. Barocco.